all bits that we share with you, or our speakers share with, and also to generate some discussion during this meeting. As in previous meetings we've had, this meeting will be recorded, and if you don't wish to be seen or be recorded, please switch off your camera. If you want to pose a question and not be heard to do that, again, that's acceptable as well. And we would encourage people to use the chat box. That's on the top of your screen, and it looks like a little speech bubble. If you click on that, then you can type your question into the box, and we'll pick those questions up and deal with those throughout the meeting. That's not a problem. We'll try and make this as inclusive as we possibly can. Make sure people get a good experience out of having the meeting, and it's got some value to everybody. We are interested, as well as I've said, every meeting we have face-to-face are using this method of evaluation, and we'll be keen that you can complete the evaluation, which will be posted in the chat box at the end of the meeting. We'll make sure they're available to you to complete after the meeting if you're not able to do it straight away. And as I've said already, don't forget to use the chat to ask any questions. Can you share the next slide? Feedback from the month since we met, it's just gone in a flash, hasn't it? The time's disappearing really quickly. People found the meeting and the content of the meeting very informative and well organised. Something at the meeting which was useful, because again, we're mindful and understand this is a different way of communicating. It's not always as easy or straightforward for everybody. This method of communication, engagement, and gave really useful and insightful updates into what's been happening across the CCG in terms of developments, engagements, and other activities that we wanted to share with you and get feedback on and understand what was happening with those. And you felt it useful to receive the slides prior to the event. I know Lindsay sent those out on Friday. The slides, reality, aren't ready much before Friday, because we tried to make this as real time as possible, so the slides are actually worked on right until the end of Friday evening, tea time almost, when we get those ready. And you'd welcome some breakout sessions. We will plan some breakout sessions in the future with some specific sessions that people can opt in or opt out of. Some of those may be place-based specific around either Newcastle or Gateshead, or subject specific around the content of what we want to share and get feedback from yourselves on and get your views and comments on. There was a request to go over moving from slides to seeing faces and speakers. And I know Lindsay talked about that briefly, about using the 3 dots at the top. If you can't do that, you can click on any one of the faces at the bottom of your screen now, and that'll take the slides off, but it will give you the picture of everybody who's, well, I think it's up to 9 people, depending on what your access is. For some it's up to 12 people. You'll see their faces on the screen, so you'll be able to see people rather than the slides. The slides will become a small in the bottom of your computer. You can also click onto the box at the top of the screen where there's two people side by side. That list on the side of the meeting who's on the call for you, so you can see who else is on the call and get a feel for which organisations and people are represented there. I was keen to share with you our feedback we've had from NHS England around the oversight framework for patient community engagement indicator. As a CCG, Newcastle Gateshead CCG have been a green star. This is as a result of NHS England carrying out their legal duty to assess how each CCG in the country discharged their own public involvement duties, as well as a commitment for supporting continuous improvement in public participation. So look at a number of elements. It's not just this meeting that consider about this. Look at the website, look at reports we've produced, a range of activities that get involved and that they do an assessment on. And that assessment is really focused, and the process is nationally moderated again. So it's not just completed by the local NHS England team. It's sent for moderation by the national team, so they can scrutinise it and ask further questions and get challenged. And from the CCG perspective, we have to submit significant amounts of evidence and information to demonstrate what our activity. This is the 3rd year we've had this assessment carried out. In the previous 2 years, We just missed out on Green Star. We did really well, and we're determined to get to Green Star, and this year we have. We scored 14 out of the 15 available points across the criteria, which was really excellent. There's not huge numbers of CCGs across the country achieved Green Star, which is the highest award. The other ratings there are is red, which obviously means that the activity is not sufficient and needs much more work on it. Amber, which means again needs further work, but there's some progress being made. And then green, which means that they're achieving the standards that's required, but we've actually gone further on than that in the CCG. So I was really grateful to yourselves for joining our activities we have to enable us to share those online and be able to to see what we're doing, but also for the staff and the CCG who've been responsible for pulling all this together and making sure we've got adequate participation across the organisation at all levels. So Lindsay, do you want to do the next slide? Just going to briefly cover some of the engagement highlights. So we've only picked on 3. This isn't the only areas we're engaging, but these are the three highlight areas we're looking at the moment. In British Sign Language, we've talked about before, we've now got 2 GP practices who've been identified to work with our patient participation involvement team. And the aim of this work is to improve the experience of people who use British Sign Language. It is a language in its own right. It's not something supplementary to any other language. It's absolutely a language. We need to make sure people are aware of that. And it's focused really around accessibility and raising awareness of British Sign Language and patient needs and requirements with staff in primary care. Work we'll do will inform as a best practice guide, if you like, then that'll be produced and shared with the other GP practices across the CCG in both Newcastle and Gateshead. We're really, keen to get this work moving because we've had lots of concerns raised by people using British Sign Language in the past. And NHS England running some listening events for language and interpreting services, and they'd like to hear about experiences from people who've used these services. And that's services you might be using in your GP practice, could be services you might use in the hospital, or other services you need to access in terms of a health component. We're keen to understand what's worked well and what could be improved with the current service. And these listening events have been shared with stakeholders within the Newcastle Gateshead area, and they're on our website. And if you've got any concerns, any problems, anything you want to say positive about your experience with that, please use our involvement email address, which is shown there on the screen, ngccg.involvement@nhs.net, and we can pick those up and share them with NHS England, again trying to make sure you can engage as easily as possible. The targeted lung health checks, engaging on information materials and patient letters, and a range of logos have been shared with key existing groups who we need to engage with and get feedback from to make sure that the logos are appropriate and that the content of the letters is understandable and people can get some benefit from receiving those letters and understand what's required for them, what's going to happen, to have a hospital appointment and those kinds of things going forward. Can look at the next slide, Lindsay. The next slide I'm going to hand over to Lindsay, actually. I'm sure I am. I think we're going to do some myth busting for COVID people. Yeah. Lindsay, I'll hand over to you.
Yes, thank you. Morning, everybody. The forum steering group suggested this idea, and I think it is really good. Just a way of injecting a little bit of fun into these sessions, and not that they're always fun, obviously they are, but a little bit of interaction, and we'll test how this goes, because obviously this isn't something that we've done before. So I'm going to read out a few skills. So what we can do is just gauge a little bit of feedback. You could either physically put your hand up. I've froze, haven't I? So I can't. I'm trying to show you my hand and I'm looking at my horrible face there. Bear with us. I'll try and turn my camera off and then put it back on. There we go. I've caught up. Right, so you can either put your hand up physically or you could use the raise hand function, which will do this. But then you'll have to remember to lower your hand as well. So if you think it's true, I would say raise your hand. And if you think it's false, obviously you don't need to do anything. So the first one, I have to flip between screens here. So Who would think that hand dryers kill coronavirus? Do you think that's true or false? So obviously if it's false, you do nothing. If you think it's true, you put your hand up. So yeah, I think generally nobody's reacted to that. So 2 seconds, it's disappearing. My computer, because I'm sharing my screen, my computer is going really slow. Hand dryers do not kill coronavirus. You may well know that. So the best way to protect yourself and others is to wash your hands with soap frequently. And as we all know, it's for at least 20 seconds. And when it's not possible, use an alcohol-based hand sanitizer. So myth busting number 2. You have to be with someone for 10 minutes to catch the virus. So do you think that's true? If you think it's true, you can pop your hand up. If you think it's false, no. Just need that a couple of seconds. So the answer to that one is the longer a person is close to someone with the infection, the likelier it is that the virus is to transmit. However, the virus can pass from person to person in under 10 minutes. So that one was false. So well done, everybody. Now the next one, garlic protects against coronaviruses. Now I like a lot of garlic in my food, so if this is true, I should be fine. We've got a few hands raised. Oh, it's popped away. For that one, some research suggests that garlic may slow the growth of some species of bacteria. COVID-19 results from a virus, not a bacteria. So I think that's why people are getting a little bit confused. And there is no evidence, unfortunately, that garlic can protect from coronavirus. So the next one, drinking alcohol reduces the risk of infection. I've seen an advert about this recently, so I think people may know the answer to this one. So again, drinking alcohol reduces the risk of infection. So if you think that's true, put your hand up. And if you think it's false, obviously don't do anything. So have we got any hands up on that one? No, no hands. And feel free to shout out if you want as well, by the way. So the World Health Organization have released a response to the series of myths surrounding alcohol and COVID-19. They explain that while alcohol can disinfect the skin, it does not have the effect inside the body. Yeah, somebody's posted in the chat, can garlic protect you from vampires? Well, that was what they used to say, wasn't it? So alcohol use, especially heavy use, actually weakens the immune system, and this reduces the ability to cope with infectious diseases. And because alcohol is associated with a number of diseases, it may make people more vulnerable to COVID-19. So that one was false. Can people with long COVID infect others? I think this one's a little bit interesting, actually. So no hands raised there. So I think everybody, oh, we've got one hand raised.
Lindsay,
yeah.
I think I've heard some news reports where there have been people experiencing problems with long COVID, but I'm just wondering, I don't know if I've ever heard reports correctly or not, but they're probably just probably more weakened. They're probably still vulnerable to COVID, but also that they may still have the virus in them, and so whenever they're breathing without any masks, they could still possibly infect other people.
Ah, well, this is interesting because, like you say, it has been detected. I'll read this out because I think it explains it better than what I would do off the top of my head. So people with COVID-19 appear to be contagious in the first 5 days after developing the symptoms. Tests can sometimes detect generic material from the coronavirus in people's noses and throats and stool samples for many weeks, and the longest recorded is 83 days. So but this isn't necessarily active virus, and that's the key thing there. So there was loads of research and tests done to see whether they could culture it after 9 days, even if the patient still had high viral loads, but actually they all failed. So patients were very infectious in the first week to 10 days, but not infectious afterwards. So it's likely that the ongoing symptoms associated with long COVID are caused by the body's response to the virus persisting even after it is inactive. So unless you have been reinfected, you are unlikely to be infectious. So that is good news.
So in other words, it stops you from being infectious.
That's right, yeah. And the last one, will my sense of taste and smell ever return? It's more of a question rather than a myth busting, really. And I've heard some colleagues who have had COVID from March are still struggling with their sense and smell and taste. So this one says the loss of smell and taste are common features of COVID-19, affecting around 60% of those infected and lasting for longer than a month in about 10% of cases. Some completely lose these senses, others report a partial loss or phantom smells, or distorted sense of smells, and sometimes this can be described as a smell of burning rubber, pungent chemical smell, or raw sewage, which just sounds horrendous, doesn't it? But the good news from that is if that starts, that's a sign that your body is starting to repair itself and your sense of smell is slowly returning. So that is it for the myth busting session today. I hope you all enjoyed it. And I think now I'll hand you back over to Chris.
Yeah, no, that's great. Thanks, Lynn. Thanks very much. How did people find that session? Was it useful? Do you want us to do other similar things or other topics in the future meetings? We're trying to make it so it's more interactive. Where we're in the room together, it's much more interactive and engaging. We're trying to replicate that if we can using the teams.
And it could be on any subject. It doesn't obviously have to be on COVID.
Absolutely. Yeah, I can see some thumbs up in the chat box. So we'll try to do this going forward. We'll ask our advisory group to pick a subject each time that they want a myth busting feedback on and get our session on, which will be really good and helpful. Thanks, everybody. I think our next agenda item is from the Recovery College Collective, which Alistair Cameron's on the call, and Alistair is going to give us a presentation. So Alistair, I'm going to hand over to you. When Alistair's finished his presentation, we'll have a short break though to give people a chance to, counter break as we'll call it, and then we'll reconvene after that. But I'll say again that after Alistair's finished his presentation.
Thanks, Chris. Just to check, how long have I got?
The break times, well, agendaed for about 11 o'clock, so you've got till 11 o'clock.
Right, okay, because I want to leave some time for questions and stuff like that and have a bit of a chat.
That's great.
That's possible. Looking at the list of our attending, I think I know about half of you pretty well, so apologies in advance. You'll have heard some of this before, but this is for the benefit of those who've not heard any of this before. I'll attempt to give a very potted history of what we are, where we've come from, what we do, and also our kind of current position and plans for the future, and how they fit with CCG and wider health and social care thinking. Slightly ambitious, I'll try and do all of that, but here we go. So those of you who don't know, COCO stands for Recovery College Collective. It's got roots in various things that have been around in Newcastle and Gateshead for 20 odd years. But really the genesis came when a diktat came from on high from NHS England that every mental health trust had a recovery college. It's an idea that it's kind of been generated firstly in Australia and Canada, really, about people who've used mental health services, working with people who provide mental health services to generate something new, groups and courses. Having said that, the NHS England prescriptive model was a little restrictive, and we didn't think it was suitable for our neck of the woods. We'd seen what else had been going on in the country, and people had invested big chunks of money, and they'd ended up with something which looked like a further education college. And we thought to ourselves, what's the point in that? Creating something, an ersatz further education college run by the NHS, when we have some decent further education colleges, Newcastle College, Gateshead College, Tynemouth, etc., etc. So we thought, let's do things differently. So I was pulled in from Launchpad, which has always been user-run, user-led organisation, sitting in the voluntary sector, doing peer support groups and self-help groups and involvement and engagement with some colleagues from CNTW, or NTW as it was then, the Secondary Care Mental Health Foundation Trust. And we thought, well, we don't have any of the results that we've got elsewhere in the country. Let's try something a bit different. And so we made things actually not co-produced, peer-produced. So everything was steered and directed by people with lived experience of mental health problems. And it's a different way of working. We started off with doing some stuff on site at St Nick's, pulling in various voluntary sector organisations to assist in a kind of collective, collaborative fashion. Proved very popular, started to get some good outcomes for people feeling more empowered, more able to manage their problems, but also a greater sense of community. We soon outgrew those premises at St Nick's, and also thought it was a slightly retrograde step for people who live in the community to have to go to a secondary care hospital site for some meaningful activity in their life. So with the blessing of the CCG, and we have got to be tremendously thankful to Newcastle Gateshead CCG buying into the vision, we thought we'll try something different again. And we went into a big building in Newcastle City Centre where there were lots of other charities. We took over the top floor of the building called Broadacre House, and we started working in a much more fluid, less siloed way, which fits very well with the social model for health and social care that we're lucky that our CCG shares with us. So looking at social determinants, realising that nobody has health problems in isolation, they all interact with each other. And what we've discovered over the years as well is that hardly anyone comes to us with just a mental health problem. In fact, that's staggeringly rare. What we find is that people may have come through a mental health channel, be that primary care, secondary care, self-referral, whatever, but there's always something else in the mix. There's a lot of poverty, there's a lot of drug and alcohol, a lot of physical health problems, long-term physical health conditions, learning disability, autistic spectrum disorder, stuff going on, dysfunctional family relationships, you name it. Everyone's got or multi, I was going to say morbidities, but that's a medical model. They've got lots of things going on in their lives, and we need to be able to acknowledge that and recognise that and deal with those issues in the round rather than in a siloed manner. So the building we were in Broadacre House was fantastic because it had 40 odd charities in there, and we forged alliances and working relationships and spin-off projects with all of them. And that covered things, they could have been covering things like arts, mindfulness, grandparenting, HIV, music, creative stuff, theatrical things, but also, for example, diabetes. So we're able to try and provide something in one place in a fluid fashion, which would try and provide something which was both of help and enjoyable for people. Okay, I'll move on to the next slide. Okay. Hey, yes, right. So that's one of our logos. We have several according to design context. So this is what these are some of the problems that we still face to a degree in the health and social care system as it is. there isn't a service in the country which doesn't call itself person-centred. And quite a lot of them will even say recovery-focused. But we need to consider on that. When they say person-centred, is that the whole of the person? Well, too often, what happens is that a person is seen in terms solely of their problems, the deficit in it. It's a deficit-based approach. It's seeing somebody in terms of, right, you've come for some help, I will see you in terms of your diagnosis. So it's not seeing the whole of the person and all their strengths and their assets as well. It's also very that services are not the whole, and I'll come to that on a slide in a second. And yes, also as well, who defines recovery? Recovery does not necessarily mean just that somebody is making less use of the NHS. Recovery it should be defined by the individual who's going on a journey. I could spend a whole day talking about that, so I'll not say much more on that. Okay, this is one of the big issues that we hope that our approach and those of the plans as the CCG and other health and social care partners move forward in transforming services that be able to tackle diagnostic overshadowing. And I'll explain this in mental health terms, but it works in other fields as well. This is an issue whereby if somebody is experiencing, for example, a mental health problem, the key to getting help often is for them to be given a diagnosis. However, whilst that diagnosis is the key to the door to getting some help, it also carries some baggage with it, which can overshadow what's going on for you. So that if you receive, for example, a mental health diagnosis or which has a certain baggage attached to it, what happens is that everything you then do gets seen through a mental health lens. So, we've had individuals who've gone to GP and they've got a mental health diagnosis of emotionally unstable personality disorder, anxiety, and they've gone shortness of breath. It's been perceived as being a panic attack, and actually in that case, the person actually had a collapsed lung. And so, it can affect clinical practice as well, but it also affects how somebody is perceived and treated, so that they are seen in terms of the diagnosis, kind of primary diagnosis, and other issues are overcast or overshadowed. Further problem that we have is service thinking, and it's great that we have some of the best NHS services in the country. However, services that a mode of service thinking isn't serving us terribly well during the pandemic, because what happens is services get designed to meet a specific problem, and a service spec is drawn up, and as soon as you draw up a service spec, you've put down inclusion criteria. You have inclusion criteria, it's also exclusion criteria, and it's also putting limits on what the individuals within that service can and can't do. And sometimes that's too rigid, too siloed, and there's not enough thinking about what are the gaps between this discrete specialised service and other ones. And that gets exacerbated once you realise that we have sets of services in primary care, sets of services in secondary care, sets of services in social care, and then sets of services in the voluntary community sector. So we've got silos all over the place. We need to get on to systemic thinking, because what happens too often is people get bounced about. It's like, oh, you've got a mental health problem and drug and alcohol issues. Well, we can't deal with the drug and alcohol issues. We don't deal with the mental health, so you need to see somebody else about that. Or you've got COPD and depression. Well, we can deal with one, but not the other. And people get bounced about. Another issue that comes along, and it's understandable to a degree, is that too many people within the health and social care sector feel inhibited. This pressure put on from the centre from expressing opinions about those determinants which have a political dimension to them, by which I'm meaning, if people were to say what's been the biggest issue in mental health over the last 10 years, in terms of things making people worse, it has to be benefit reform. That's a political issue. whether it's big P politics or small P politics, there's a political dimension inherent to health and social care. We have, as I've said, some of the best services in the country. However, we have some of the poorest outcomes, and that's due a lot to social determinants, as people's poverty, their housing, their education. Those are all political issues. And yet, in a way, health and social care services kind of pretend that's not happening, and feel inhibited from speaking out. And that's a problem, because we need to tackle issues like poverty to see a real sustained improvement in people's mental and physical health and their emotional well-being and their ability to flourish. Okay, this is a slightly trite issue, a slightly trite bit of maths, but certainly in the field of mental health, and I think it's the same in a lot of other specialties, even if you are receiving quite a high level of input in averaged out unless you're an inpatient or something like that, or having a procedure, you're lucky if you get, if that actually amounts to more than an hour in any given week from a healthcare professional, and so that leaves another 167 hours in the week, which need to be filled with stuff which is at least complementary and congruent with the kind of treatment package to enable that golden hour of expensive clinician time to work. It also, if you put it also helps us to put things into perspective. Services will often think of themselves as the most important thing in somebody's life. However, if you only see somebody from a service for an hour in a week, then actually, it's a little bit grandiose of services to think that they are the most important thing. And actually, there's lots of other stuff which is more immediate in people's lives, which can take priority, and we need to acknowledge that. Their immediate surroundings, the people around them, can have a bigger influence and certainly have a more pervasive influence than 60 minutes in a week. At the moment, that's also exacerbated because people at the moment, particularly with the pandemic, aren't necessarily able to think in terms of a week. It's just getting to the next 24 hours. So assurances that we're seeing from some services that things will resume, back to normal. We'll pick things up again, in spring and summer next year. To be honest, they might as well say we'll pick things up again in 10 years' time. It's too far away. So we need to acknowledge that that people's time frames have shrunk. People's ability to see to endure things into the future is under strain. Essentially, if you want people to have a meaningful life and be able to manage whatever problems that they face, then yes, there are the direct clinical services, but we need to encourage and foster people's social networks and social connections and make it so that they're beneficial to people's lives. It doesn't matter what diagnosis, whether it's a mental health diagnosis, a physical health diagnosis, stuff going on in related to your wider life. We need these protective factors of somewhere to go, something to do, some people to do it with. If you've got those three in place, then actually that's the fertile ground for preventative work. But it's also, those are some of the conditions which will allow for specialist interventions to have the most beneficial impact. So this is kind of the Rococo approach. We do groups and courses, loads of collaborative stuff. We basically have spent the last 5-6 years saying yes to everything. Oh, you want to do a stand-up comedy course? I will give that a crack. You want to do something on reducing the range? Yeah, we'll do that. So we generate it, and we generate our own workforce. People come to us, signposted, self-referred from secondary, tertiary, primary care, from social care, probation, all all corners of the all corners of Newcastle and Gateshead. And they will they'll often describe themselves in terms of what's wrong with them. Or we want to turn that conversation on its head and say, okay, but you've got a set of skills because you stayed alive, you got here. Let's work with what you have got rather than what you haven't got. What is it you like doing? What is it you're good at? Because you have survived, to the point that you're here today, which is more than many people, sadly. So let's work with what you have got and build it outwards. So there's stuff in there about influencing, being an incubator for services, but also trying new ways of working. So peers in charge, that's been one new way of working. Another new way of working has been the kind of cross-organizational working. We have at the moment on our staff essentially three different employing agencies with everybody, four different employing agencies, and this is just among core staff, but they're all operating to COCO standards. It's a way of breaking down silos between organisations. But we also want to break down the differences between primary and secondary care, health and social care, and the distinction, which is a little bit arbitrary sometimes, between service user and clinician. The clinicians can, are humans too. Surprise, surprise. Managers are human too, and it's allowing everybody to express a little bit more of their humanity and pushing against some of those boundaries. We know some boundaries are there for necessity, for safeguarding, but a lot are there simply out of habit or for kind of organisational interest, and those are the ones we seek to dismantle, to be the change we want to see in others. Because it's essentially what we're seeking to do. We know that in Newcastle and Gateshead, there's a great wealth of knowledge. There's knowledge that people have acquired through learning, going to medical school, doing nursing, doing psychology, social work, etc., etc. There's that kind of academic knowledge allied with the practical learning on the job. There's also knowledge that people have of their particular geography, their footprint. There's knowledge that people have of differing communities. This could be communities of culture, there could be communities of faith, there could be communities of shared experience. And then it's also the knowledge that people have, the experience that they've gained through going through the mill, through having a rough time, coming through the other end and knowing what's worked for them. So these are all different bodies of experience, and we need to kind of pool those for the best benefit of everybody. So so clinicians need to learn from experts by experience as to what works in the real world and what doesn't. But we all need to learn from different communities as to which approaches are going to achieve the best outcomes for them. That's part of the moving out into society and making sure that system and the society are as intermeshed as possible, and we don't regress to a kind of siloed service type of thinking. So, where are we now? Well, this is our, we've produced lots of things. We've got literally thousands of people on our books. We don't discharge people because that's a fundamental. We don't want to follow that kind of service model. We're there for whenever people need us. If we don't see them for a few years, that's grand. They can pop straight back. Lots of groups and courses which split into ones which relate to kind of managing emotions, DBT skills, anger management. So ones that relate to certain sections of the population, like LGBT, mental health, or the mental health support group for parents and children who are going through CAMS or SIPS services. And there's a load which we do because people enjoy them. The last thing, in a way, we'd like to be able to do mental health without using the word mental health. So people come to us and our partners and our collective, and they come to us because they want to, not because they feel they have to or they need to. They come because in the same place, same building, they can maybe do a bit of yoga, a bit of music, a bit of mindfulness, also get some advice and tips on their welfare rights. the same time, they might be wanting to disclose about some domestic violence, and equally, a little bit of managing their bipolar. Do that all in one place, so that people don't feel ashamed of who they are. We recognise all those aspects and facets of who they are. We have a base in Gateshead within. Some of you have been there. It's a cracking base, and we're very sharing. So that's used by it's a base that we have, but it's used by lots of people. So Tyneside, Northumberland, Mind, Recovery Connections, young lads and dads. They all get to use it because we offer them stuff, they offer us stuff, and it all becomes one nice collective. No, it's not Saltwell Towers, unfortunately, but it's the kind of training pavilion with the bowling green attached, just by the lake. And this is where I'm speaking to you from right now, which is our big new building, huge, much bigger than like anyone was expecting, in Carlisle Square. So we have 5 floors, each of about 5,000 to 6,000 square feet. So we've got 25,000 to 30,000 square feet, and again, it's kind of shared space, which we want to create a fluid community of people who wish to do good and who are canny. So we've got Edge North East to do young people, county lines working at the minute. We've got social justice lass who does work. She's got a big space, and we're doing quite a lot of stuff to tackle the pandemic in terms of food and toiletries and sanitary good relief, getting those packages out there. We've got Workers' Educational Authority. We're doing stuff with changing lives. You name it, everyone's got a stake in this, because that's kind of what we aim to do, to produce a collective. And it's great, and it's exciting, and obviously we're hitting the odd wrinkle here and there with things, but we're just beginning to resume some in-person work, because the building being a work in progress, we have some completely open plan empty floors, which are perfect in the short to medium term for doing socially distant 5 meters apart, and provided they can hear in this big open plan spaces, we can get activities going. However, we're also aware that a single base is not enough. So we'll work, 2 bases, one for Newcastle, one for Gateshead. It's not enough. So we've got a lot of work coming through, which we hope fits with the direction of travel. That's a managerial term, but the direction of travel in which health and social care is going all together. So we're trying to do some work to get some of our courses, some of our partners, organisations, courses, and our approach out into primary care networks and community treatment teams and other community hubs, training people in there in both in our approach, and we give away our training materials. Rather it was out there being used by people than stuck in some proprietary kind of, you can't have that because it's ours. That's very much against the nature of what we're about. If there's something good, get it out there, get it benefiting people. We do measure lots of things. We're not completely fly by the seat of our pants. But what we do measure isn't really in clinical terms. There's the odd clinical measure, quasi-clinical measure that we use, like SWEM-WEBs, shorter Warwick Edinburgh mental well-being scale. But really, it's about things like people's sense of self-worth, recognizing their strengths, feeling connected. And on the connected front, we do, if we do nothing else, what we aim to do is to get the number of people that somebody interacts with in a given week up. Just because having that personal support network is absolutely critical to managing long-term conditions. It's critical to managing your mental health. It's a tremendous preventative measure, and it's proved very hard. during the pandemic to do this. I mean, we've gone digital, stuff on Zoom, etc., etc. But this week with the resuming of some staged, phased, small group work, hopefully we can resume some of the face-to-face stuff, and we'll see a lot of good arising from that. This is some of our spiel on the outcomes that we have. People saying less to their GPs. And so I see Carlisle Square, we are open. Number 1, Carlisle Square is our address. We're not open to the general public, as it were, because we're just this week we're phasing back in some group work. So we're trialing that with people who are just on our books. So people are already on our books, inviting them back in to see how the flow of people in the building, etc., works. We're doing that in little groups of 6. And we're optimistic it should work because we've done a little bit of work, a bit like that in Saltwell already, and we did some work for the staff of the QE hospital in Saltwell as well. So yeah, we can provide data on everything, but this brings us back to what I was talking about earlier, some of the kind of the social and political dimensions. From the data of the people that we work with, we know that an awful lot are not in relationships, so they lack some of that social protection, the personal network. But most importantly, I think, is this one which shows that people that come to us tend to have, I was going to say, multiple and complex needs. The needs aren't complex. The needs are entirely understandable when you hear someone's story. However, the current system in which we work finds these individuals complex to deal with simply because it has a siloed approach and people are presenting with more than one issue, because guess what? They're fully rounded people who've got lots of stuff going on for them. But what we've found is that overwhelmingly people are coming from the most deprived areas. Poverty and poor life chances are huge determinants of this. The correlation is enormous. So, we aim to have, obviously purpose, reach, and impact. But whilst we work with services and organisations, our approach is really about systems. And married to that, yes, we want purpose, reach, and impact to work on individuals and on practitioners, because one of the things we do is create a kind of experimental zone, a safe zone. So we do have some clinicians who work with us, but they're allowed to bring a little more of themselves to their role. They're allowed to work in a way that maybe they feel deterred from doing in other settings. So we give people a little bit of freedom. So we've got there's a psychiatrist, for example, who turns out they have themselves used mental health services, and they're quite comfortable relating to that in our place, and they're quite comfortable bringing their guitar and joining in groups. Doesn't mean that they've lost their clinical knowledge when they pick up the guitar. It just means that they're showing more themselves, more rounded, and that's helped to foster some really good working relationships. So while we work with individuals and practitioners, the key is communities, and I think yes, there's no denying it, whether it's big P or small P, there is a political dimension to this. I think that is it. Yeah. So, any questions?
If you have any questions, can you pop your hand up so we can bring you into the discussion? I can see your hand up now. I can't make out who it is because it just says add guest.
Oh, Alan Guest.
Oh, hi, Alan. Yeah, I can see now.
Yeah.
Thanks. Hi, I got you.
It's just wondering, how has the pandemic affected the way you provide your services? Many people are relying on likes of Zoom and Teams, and I'm just is that the way you are providing the services now?
the bulk of it, yes, we had to make a big step, and it does present us with a kind of dilemma going forward. Almost like to switch everything from in person to doing it electronically, and we're acutely aware as well that excludes a lot of people because of digital exclusion. People just not having the resources, sometimes the skills, but it's mainly not having the resources or the kit or the finance to be able to do online stuff. So we're aware of that. We do a lot of stuff online, but we're now at this juncture where we're zooming in person, and it's almost like I've got to do double running, and that is a kind of pressure point that we're experiencing, because we moved staff and volunteers and people who've generated ourselves who then take on roles, doing stuff online, but now we need to do both stuff online and in person. On the people who are excluded, we've done quite a lot of work in producing in newspapers and stuff like that, which has gone out through community hubs, with food parcels. We do work with mutual aid groups and things like that. But yeah, the digital, it's fine for what it is. It's possibly allowed some people to do things which maybe we wouldn't have seen them otherwise. But our view is it's still it's nothing like in-person work.
Siobhan, you've got your hand up next.
Hi, Alistair. I'm really interested in what you talked about in terms of the big P and little p political. And I think it's been a long-standing issue. And I suppose we haven't got time today, but what would your first and second steps be in how we might progress and move forward on introducing some of those conversations into the things that you described today?
Oh God, right. We got time for me. Well, we haven't got a lot of time, but what I would say is, I think, and there have been occasions when this has happened, but I think actually, certainly those of our more prestigious, those who've got more status, health and social care leaders, should not be afraid to speak up, speak out. So that, for example, we've got this ICS which covers North Cumbria, the whole of the northeast, and it's, in theory, it's going to be a big feast of some sort. And so that's got sufficient clout, one would think, for its leaders to be able to say to, for example, DWP, say, look, there's no point in investing in the NHS if your benefit reforms are making people much worse. You're pissing in the wind otherwise. Probably not say that directly, but so there is some of that, but keeping the pressure up and not being afraid to speak up when you can see a direct detrimental effect to the people that we serve.
Lindsay, you've got your hand up for a question.
Yeah, I haven't got a question. It's just to say that Kate's got 2 questions in the chat. So what proportion of carers come through Rococo, and are they across mental health concerns or specific? And then the second question is, have you got specific routes in and out, i.e. partners?
I'm not sure I understand the specific routes in and out. I mean, we've got a load of partners. I think it's 70 odd partners at the moment, and we're open to work with anybody who's can, to be honest. So there's always more coming on board. We're very happy for people to, we're very happy for people to move on, but we don't have a kind of. We're also very keen to avoid the habit that some services have of trying to hurry people along or chase people, not quite chase people out, but if people want to stay with us, that's great, and they want to, that's not a problem. But the ideal is that somebody comes to us and they'll maybe do a bit of joint work with us in one of our collaborative projects, and then they get out and they'll do stuff. We do stuff, for example, Time Away Archives and Museums, And before long, they're spending more time at the Shipyard Gallery or the Discovery Museum. It's like, great. And that's fantastic. And, eventually spending all the time there and very little with us. That's the kind of perfect, but there isn't we don't set a time frame on that or a kind of proportion. And also because mental health and other problems fluctuate, so we know that we might not see somebody for, as I said, a couple of years because they're going off doing other things, which is great. It's more to life than your mental health. But stuff happens and they want to come back, and that's nice and straightforward. On the carers, that's a tough one because, particularly in mental health, when people are in relationships, it's often with other people who've been through the system themselves. So there's a lot of kind of people who are both service users and carers at the same time. I would say on our books, a good 40% of people on our books have some sort of caring responsibility beyond a kind of parental caring responsibility.
Okay, thanks very much, everybody. Alan, I think you might have had a supplementary question. I think I was talking over you. Sorry if I did.
No, I haven't got one. No.
Oh, okay, thanks very much. Okay, it's almost exactly 11 o'clock. So that's been really good, really helpful for everybody on the call, and great for me to hear some of the things that you're continuing to do and the work is progressing. It's really really exciting time still, I think, for your services. We do need to retain our engagement with you and make sure we can support everything you need to do, moving forward and having your services as accessible as we possibly can. I think it does make a big difference to the people out there who need to use those services. I'm going to propose we now break just for 10 minutes, folks, give you a chance to make a cup of tea, have a comfort break, and we'll come back at 11:10. I can ask you to put your cameras on, turn your cameras off, and put your microphones on mute just while we have the break, and then we can come back together again at 11:10. Thanks, everybody. Hi, everybody. It's 11:10. Can we begin, please? I think the next agenda item is around the Big Orange Book. You remember we had a presentation some time ago about the Little Orange Book, which is where the CCG had worked with primary care and the practitioners to develop a book to support parents of young children with minor ailments and other things that happen to young children. This book moves on from there and deals more with the needs, or will deal more with the needs of adolescent children, teenagers. Catherine, are you on the call to start the presentation?
Yes, Chris, I am. Sorry, my computer's a bit slow.
No, it's okay, Catherine, that's fine. The slides are on the screen. Remember, from the slides, if you click on one of the faces below that of an attendee, you'll lose the slides and see the participants of the discussion, but you can still see the slides in the bottom of your screen. Thanks, Catherine. I'll hand over to you.
Thank you. Thank you very much for asking me to come along today to talk about some of the work that we're going to be doing in Gateshead around developing, like Chris said, a big version of the Little Orange Book. Can we move to the next slide, please? I just wanted to give an overview of the team because since I last spoke to you probably over a year ago now, we've had some changes and the team's very much focused in Gateshead at the moment, and there's equivalents in the Newcastle system, and we do try to work across and share any good practice. So Lynn Wilson's the director of the Gateshead team, and as you can see, there's a number of people working on different areas. Now, I just wanted to cover some of those areas today before we go into talking about the Little Orange Book and the Big Orange Book. So if we can move to the next screen, please. We've decided on 4 key priority areas for children, young people and families, and that's around the sick and injured child, and that's very much around the Little Orange Book, as Chris mentioned, around early years and prevention, and that cuts across all of the ages and very much where we see the teenage book going to fit into. We also have another big area around special education needs and disabilities, and that's across our special schools and our mainstream schools to see how we can best support those children. And then the other key strand is around maternity services, to make sure that we give our young children, babies, the best start in life, and again links into the early years and prevention. Next slide, please. So for the early years and prevention work that we're doing, we're very much keen to work with our colleagues across the Gateshead system, and we're linking with public health around immunisations and obesity, and these are some of the topics that we think might be of an interest to include in the Big Orange Book. We also link very much with our 0 to 19 service, with health visitors and school nurses. We've, during COVID, had really good contact with the 0 to 19 service and trying to reach out to our young people and speak to them directly through virtual sessions. We're very much keen on improving the emotional and mental health and well-being of our children and young people, and are keen to speak to them and also include this in the teenage book about what's relevant for them and what helpful information they would need to receive. And that may also then lead to us looking at our commissioned services. So currently we're undertaking a speech and language therapy review, which impacts on one of the key areas that I talked about around special education needs and disabilities. The school assemblies I'll talk to you about a little bit later, because that's very much where the Big Orange Book's being driven from. And I think I'll give you a little bit of history for those that weren't at the last presentation I gave you around the Little Orange Book and why we think it's going to be really important to develop a teenage equivalent in schools. And very much everything we do is around the voice of the child and making sure that whatever we develop or implement includes the voice of the child, also that of their families and parents and carers, around what are their needs and how can we best help support them across the system. Next slide, please. So under the Sick and Injured Child programme of work, there was a few strands as why the Little Orange Book came around. One was about trying to improve access to our primary care services, because we were hearing that it was a struggle to get appointments, or you couldn't get an appointment or speak to a GP on the same day. I'm pleased to say that pretty much all of our practices now in Gateshead, they do offer consultation appointments or a discussion appointment, and they will see you if they need to that day. We also support our clinical leads in producing some of the topics that were included in the Little Orange Book, and promoting and helping how a number of women received the flu vaccine and then the school-aged children received the flu vaccine. So the Little Orange Book, we did a survey in A&E around why were parents and carers going to secondary care services or work, which is our hospitals or walk-in centres, rather than attending primary care. A lot of the time they felt that they couldn't get the appointment, or the GP just didn't understand what they were there for and that the child was really poorly. So we looked at some common themes and topics and wrote those around how they could be best supported through primary care, how we could promote self-care, a clear understanding of some minor illnesses, how long it should last for, do you need to go to school or not? And it's been really well received by parent carers and professionals. We've had lots of requests from families to have additional copies so that grandparents can have these, especially when they're providing the childcare, which we know they do a lot of. So following on the success of the Sick and Injured Child in the Little Orange Book, we thought that we would like to try and develop a teenage book. If we could move on to the next slide, please. And the focus around the teenage book really will start from age 13, but we are aware to look at transition point from primary to secondary school and what the emotional and wellbeing effect on young people might be during that stage. But from 13 years up is what's going to be our focus for this book. If we can move to the next slide, please. We're very much in the early stages of developing this resource. And I mentioned earlier around the school assemblies, and I'll talk to you a little bit more around those and what we do there, because this book will be key to supporting those, but we also think it will be key for parent and carers to get information if there's any concerns around their young person. It's in the main a Gateshead book, but will be a pilot stage, and if it's successful, we would anticipate that we would share across Newcastle Gateshead, just like we did with the Little Orange Book. We're very much trying to develop this as a system approach, linking in with the primary care services, getting viewpoints from our GPs, secondary care and community care, making sure that if they're seeing any concerns that we maybe include those topics, and around health and education, and in particular mental health. The book will contain specific advice on topics. They're very much around body image, focusing on social media, lots of things that we think are important. However, they might not be to that young person. So we're very keen to meet with as many young people as possible as we can to see what they think would be useful in the book. We met with young people a few weeks ago, and they have decided that they'd like to be some champions for us to help us develop this book going forward, which is fantastic to have that engagement. And we're hoping to go out to schools to ask if they could help design the book, what children and young people would use, what they wouldn't use. But it really much has to be driven by young people to make sure that it's going to be relevant to them. Next slide. Thank you. We started the school assemblies from year 9, so from age 13 up, to try and encourage children to be aware, or young people to be aware of what the value of going to see their GP for is. And just listed on the screen here are a few things and issues that would tell children and young people that you're able to go to your GP and discuss some of these issues with them. There's very much a view that you couldn't really go for any of these type of things. It would need to be because you had earache or things like that. So it's trying to communicate to the teenagers and young people what it is that actually a GP could help you with. Next slide, please. We also very much link in with the school nurses because they have a big role in schools and meeting with young people directly, which often we in health don't get to. And they talk to them around keeping healthy, obesity, physical and emotional health, and relationships. And these have always been topics that have been well received. So we do think that these might be included in the big orange book, and we'll have to think of a name for it. So if anybody could think of an attractive name, or how we could try and find out what might be attractive to call the book going forward, that would be really useful. So the book, we would think, would support the year 9 assemblies. So when we're talking to the children and young people at the end of the session, we would like to make sure that we leave them with something. At the moment, the assemblies are really welcomed, and we ask for a survey and feedback. But we've thought that we could go the next step and leave some information with the children and young people, because we can't cover all the topics in depth. And sometimes we're not actually sure if we're hitting the right ones or not. Next slide, please. At the very beginning of the assemblies, we always ask the young people 3 questions. The first question being, can the young person at the age of 13 upwards make an appointment to see their own GP? The other question is around if they talk to the GP on their own, if they feel stressed or down, and would the GP have to tell the parent or carer that you'd been to see them? And how we've handled this in the past is very much with a voting system, so yellow and green cards. And we ask the children to vote to see whether they feel that they can do this or not. We've found very much at the very beginning of the presentation that the children vote red, that they wouldn't be able to go to the GP for these 3 types of things, or that we would have to tell the parent and carers they've been there. So the GP and the school nurse talk about how once you're over 13, you can go and make an appointment on your own, in that you can go and talk in confidence, and you could possibly take a friend along with you. I think that we always stress the condition that if we've ever thought there was something serious or a safeguarding issue, that the GP would then have to share that. And we're very clear with the young people when we're giving the presentation that they understand that. Next slide, please. So the teenage book, before we move on, I think what we would like to try and find out is what parent carers might also want to see in that book and how helpful it would be. If anybody knows of any existing groups of young people that we're not aware of, we're very keen to tap into those and work across the system to try and link in and speak to those young people to get the book developed. It's very challenging times at the moment with COVID, so lots of schools actually don't want us in. But what we're doing is to look to try and do virtual sessions where we'll record a GP and the school nurse talking, and use some interactive measures for the children to vote about what they might like in the book and what they might not. Other work that's going on, as I mentioned earlier, was the speech and language therapy review. Next slide, please. The review's been undertaken by the CCG and working very closely with Gates Clinical Commissioning Group and the Foundation Trust to look at the service that's provided across the system for our young people, to make sure that we're mapping out where the provision is, if there's any lacks in that provision, and how we would develop a service spec that would meet the needs of our children and young people. Next slide, please. I know that I've been to talk to you about in the past around the special education needs and disabilities, so I've just put up the slides that I've previously shared with the group. I don't really want to go through this in depth, but just that we are expecting a visit from inspectors in Gateshead to look at how we've managed our special education needs and disabilities during COVID and supported our young people. Inspectors are going to be keen to speak to parents and carers right across the system and young people around their experience, but in particular 16 to 25-year-olds. So again, we'll be sharing some of the information and the links to the survey in the near future. And if you know that you can share that across your systems and your services and any groups that you know of, that would be really helpful to try and get that feedback. Next slide, please. For SEND, our key focuses are around education, health and social care linking together, and making sure that the education healthcare plans are written in a good way with meaningful outcomes, that training's being developed across the system, and implementing things such as infection prevention control training to schools, making sure that we look at the transition points. And again, this links into the Big Orange Book. To make sure that we get the right information in there, or that we are actually talking to the right children and young people. That's quite a challenge, to make sure that we can meet with young people at the time that's convenient to them. So we're very keen to try and understand when groups of young people are meeting organised that we can join in with. Next slide, please. We've developed a communication star from the CCG that we share with GPs, and what we're trying to do next is change this information on this star to be with mainstream schools and special schools. This star provides key professionals or services that are involved with the child and young person and where they can go to for support. So again, when we're looking to develop the teenage book, it's very much about what services and things we include in the book that will make sure that we're put on the communication star that could be shared across the system. It's our hope that we'll develop something similar for families and parents and carers as well, so they could get information and help where they need that. Next slide, please. I've mentioned transition a few times today, and I think in particular it is really key because we need to include some of this information into the Big Orange Book when we develop that. There's different key points for children and young people, but for young people going from primary to secondary is going to be one of our big focuses. And then when they're preparing for adulthood and they have to start to look at which colleges or schools they may want to move on to, or working opportunities. And I think it's really important that we start to identify this early with our young people from about 14 and make sure that we cover any of the concerns that they have in this booklet that we're going to develop, and make sure that there's clarity of the information and sharing responsibilities across the system to allow a smooth transition for these young people. We know that we need to develop some clear pathways across the system and timescales. The young people have already told us that. So in the transition book, it would be really, in the big book, would like to include what the pathways might look like or explain throughout the topics where they might need to go for help. Next slide, please. So the transition steps are there that we see, and it can be from any age, but as I said, we are quite keen to do that from a young person age upwards of 11, more again a focus around 14, and where at the moment children and young people tend to be under paediatric services or specialist children's services. From 18 there won't be, so we'll need to have a look at how we can hand over to the GP and offer learning disability health checks if that's relevant, and make sure again that when we cover this in the Big Orange Book that it's accessible to all children and young people. Next slide, please. And then finally, the other key area for us is around maternity services. So we are going to be doing some work in the future around the some key national documents, Saving Baby Lives and Better Births, looking at the reduction of number of women smoking in pregnancy, but also looking at smoking across the board, because we do know that young people do start early. And again, this would be a focus in the Big Orange Book. Looking at postnatal and perinatal mental health, and looking at reducing the number of stillbirths. Next slide, please. Here is a list of the team's contact details. So if there's anything today that you would like answers about, or I haven't covered today and you'd like to know some further information, they're their email addresses, and I'm sure that we would really be happy to get back to you if you needed clarification on anything we've discussed today. And I'm happy to take any questions or queries that anyone has.
Sorry, I couldn't get the microphone to come back on. Catherine, there's a question in the box which talks about transition from childhood to adulthood, and is this support available to 18 years or 25 years?
Yeah, so we're really trying to strengthen that, and working with our local authority colleagues in health and education and social care together to make sure that we address transition. It can start from very early, so from birth, but particularly we're going to focus on from age 14 upwards, making sure that as a child starts to leave those traditional children's services and moves on to a GP becoming the lead practitioner, that's as smooth as possible, offering multidisciplinary team meetings for everyone to get together to discuss the child and their condition and what some of the issues have been with that child. And it's very much a focus on 18 to 25 in line with the Children and Families Act guidance that we have.
Okay, that's helpful. Thanks, Catherine. Any other questions? I can see some hands up. I'm just going to check who they are. Bit slow. Dan, you've got your hand up, then Alan.
Excuse me, Chris. My question's just been answered.
Oh, is it okay? Thanks, Alan. No bother. Dan, you've got your hand up.
Hi, Catherine. It's Dan from Involved North East. I've got, I guess, kind of three quick questions. I think Alan's kind of mentioned one. I guess looking at the focus of the book from 13 plus, I'm just wondering, will there be any focus on that 18-year-old range? As within Newcastle and Gateshead, you have, 50,000 plus students, and as an 18-year-old moving to the city, that's probably the first time they may become purely independent and look after their own health, and possibly maybe looking coming to a new city and looking for support around those issues. My second question would be, is it set to be a book? And is a book the best medium for this? Is it the first thing that they'll lose or the first thing they'll put down? And how will it be maintained if it is a book? Because obviously there's as we all know, as soon as something goes to print, it's often out of date. And I guess if it is going to be across those broad ranges, how's the resource going to factor in and be flexible around kind of religious and cultural views? Because obviously within Gateshead there are quite a significant Jewish population, and within even in Newcastle, the BAME community has very different views, even looking at the difference between Catholic schools and their sexual education.
Right. Thanks, Dan. They're really good questions. I think at the moment we're very much in the early stages, and it's about getting the focus of it right. So it is going to be quite wide range, and how do you make sure that it reaches a 13-year-old and also reaches an 18-year-old? And I think that's why we're very keen to hear from young people and get their views on how they think it would work and what would be interested to them. Because of special education and needs, the drive is for us to be very much a 0 to 25 service, and that's always at the forefront of what we're doing and when we're developing things, to make sure that it's accessible as much as possible to all of the children. So we won't be excluding anyone from that, and we'll be gathering the views and then thinking of the format. So nothing's set in stone. It's very much early days and will be driven by our young people in Gateshead. So I hope that answers your first question. Around whether the book would be the best media, it's very interesting. We did some research with the children and young people when we were doing things like the Little Orange Book, or we've done school assemblies. We've popped in some extra questions around what they'd like to see. When we've talked about apps and things, they've very much told us that if it takes storage up on the phone, they'll just delete it straight away if it's not relevant to them. So one of their ones was, if there's a fight on the schoolyard and I haven't got enough room to video it, then I'll delete the health app straight away. So that made us think about, what do we need and what's the best media? And I think with the Little Orange Book, we've found that people have liked the value of holding it and felt very much trusted around what they were reading, because obviously when you can go on the internet, you can read lots of different things in different ways and interpret it differently. So we're keen just to try it out, and I think the magazine format is what we're thinking of at the moment, but we'll be guided again by children and young people. And I think it's very much something after those assemblies, when we've talked to the people, it's something just to start off with, to leave them with. It could be that it's something that they take home and a parent carer can pick up and read, and maybe have those discussions with young people. And again, this will be something we talk about when we're developing that with young people. Is this actually, are we right in this thinking, or are we wrong? So it's very those early stages. And again, you're very much right about the cultural differences in Gateshead, and they'll be exactly the same that we faced when we were developing the Little Orange Book, and we've very much included the Jewish community within that to make sure they were happy with the content and they felt that it was okay to be shared, because we know that sometimes what we think in our culture is different to another culture and isn't acceptable. So we're very much aware that we need to take that into account when we're developing it. And also around the young people, driving that forward for us, and we have to adapt our assemblies. So our Catholic schools and the Emmanuel Foundation at first weren't very keen on us going in with the assembly, the way that it was written and how it was presented. Mm-hmm. When we spoke to them directly, it was very much around that sexual information that we were sharing, and they weren't keen on that. Rather than just say, well, that's the presentation and that's what we deliver, we've very much tailored the sessions and removed some of that content. So we're still getting in there and talking to those young people about very key things. And again, we're hoping that with the teenage book, or however it is, that would feed into those conversations where we're not exactly talking about it directly to the young people in some of those settings.
Thank you.
Any other questions or comments for Catherine? Okay. If we move on to the next agenda item, which is the Healthwatch update. Siobhan, are you doing that, or is Cynthia on the call to still do it still?
It's
Some
me.
of the Siobhan's do. Yeah. Okay. Hi, Siobhan. Welcome in your new role.
Yes, thank you, Chris. Hello, everyone. It's lovely to see you all. I'm the new Chief Executive of Healthwatch. I've been in post since the back end of October. Sadly, I had to take a couple of weeks unexpected leave since starting. So I will do my best on my presentation. It's the second one I've done, so bear with me. And it's nice to see some familiar faces on the call. So just in terms of an update from us, we are still using the priorities that were developed by Healthwatch England in response to the pandemic. So I'll update under each of those. So first of those is communicating key messages to the public. Since the last meeting that Cynthia presented back at, we've continued to be active across our social media platforms, Facebook, Twitter, Instagram, LinkedIn, etc. As you'd expect, we've covered a lot of topics related to COVID. So we are promoting the Because We All Care Healthwatch England campaign, which is gathering people's experiences of local health and social care services during the pandemic. We also did features on the start of the national restrictions in lockdown 2 and how people with COVID and alcohol issues can be supported. We've presented on how the Christmas COVID bubble will work and the implementation of Tier 3 restrictions. As well as COVID-related content, we've also covered things like the importance of flu vaccination and the annual health check for people with a learning disability, things around safeguarding, preventing abuse of adults and how to report a concern, children and young people's experiences of accessing health services, a variety of topics. In terms of information gathering, we have, since starting, I've kicked off a piece of work that's assessing all of the information that we've gathered since March from our own COVID-19 survey, the Because We All Care survey, and also the information that we get in either through phone calls, emails, or through community outreach activities in the form that they are currently taking. In terms of themes that have emerged that we are progressing with, and I think Cynthia probably mentioned these the last time, dentistry has featured quite heavily. It's featured quite heavily in the nationally in the Healthwatch England campaign. And we started last week to undertake an open shop across all practices in Gateshead and Newcastle. And we're asking about what the current offer is on routine, emergency and private dental work. And we're trying to understand not only what the service offer is at the moment, but also to identify if there are any health inequalities emerging around people's ability to pay for services. And depending on what we get back from that, it's likely to become a larger project. Access to GPs, it was the top theme in our Newcastle reviews and the second theme in the Gateshead reviews. And people are highlighting to us the difficulty in getting an appointment, difficulty in getting a face-to-face appointment, support for long-term conditions. Interestingly, in terms of feedback on the use of virtual appointment, it's relatively small numbers, but the feedback that we've had so far is that the majority of people have reported good experiences. And we've had really positive feedback around NHS and services staff around their attitude and manner. So in Newcastle, we received 80% of positive responses around that. And we're looking at how we would promote that as a good news story to act as a platform for us gathering more data. I think access to GPs is an issue that's been around for a long time, and we will be looking at what our next steps will be around that. At the moment, we've not received sufficient insight to prompt a specific project on secondary care services, but things to note: costs of hospital parking, which comes up frequently. Again, positive reviews of staff attitude to care and customer service, and a small amount of data that we will need to follow up on in terms of mental health support. But it has been highlighted to us that people are struggling to get support, and some worried about the impact this will have in the longer term. Numbers are quite low, so we would need to look at that again. Other things that we're doing is one of the team is working with the whole system, and we're developing a number of case studies that will support the Ageing Well strategy. Our case studies will be used to complement the content of a report that's being written currently and kind of add a real life element to that. In terms of signposting, we are working at the moment on collating a set of videos with organisations to provide information about their services that we'll promote across social media and our website. We're looking at working at the moment with the Stroke Association, Josephine and Jack Project, St Oswald's, Tyneside Mind, the Men's Pie Club, NUFC Foundation and Diabetes UK, and we've got other conversations ongoing with other organisations. In terms of supporting local communities, across the team of staff and volunteers, we've got 7 people undertaking weekly befriending calls, and we'll continue to do that for as long as is needed. That's a really brief overview of what we are doing. In terms of starting the role, I am in the process of and interested just in getting out and about, not literally, but virtually, to meet with and talk to people and just to get their views on Healthwatch and around our priorities, and just so that people know who I am and feel that we can develop relationships even though we are working in this virtual way. So if you see an email from me inviting you for a cuppa and a chat over Zoom or Teams, it would be great to meet with you, as many of you as possible. And that's it from me, Chris, unless anybody's got any questions.
No, very comprehensive there. Thanks very much, Siobhan. Loads going on there. I can see Pat's got your hand up, Pat. Pat, are you on mute? Can you hear me? I don't know if she can.
Can you hear me now?
Can hear you vaguely, yes, Pat. If you speak, we can hear you a little bit.
When you're looking at dentistry, if you could ask the question about pregnant ladies, please, and their access to dental services.
Pat, I didn't quite catch that. Can you repeat it?
When you're querying what...
I'll speak, Siobhan, I'll speak it. I heard it,
Okay.
it's okay. Yeah. Pat's asking if when you're doing the dental work, can you ask specifically around what the plans are for pregnant ladies? I mean, they do have specific access requirements to dentistry, and it would be a shame if they could have that, going forward. Is that what you said, Pat, isn't it?
Thank you.
Yeah. Any other questions? Any other comments? Alan, you hand up?
Yeah, I'm just wanting to take the opportunity to. I'm a Healthwatch Gateshead champion, Siobhan. I'm just taking this opportunity to say hello and hope to see you sometime.
Hello.
Okay. There's no more questions. We'll move down with each other. But thanks, Siobhan, and welcome to Newcastle Gateshead in your new role.
Thank you.
Yeah, no bother. Well, enjoy work with you again. So moving down, the next agenda item, I think, is question time. Don't know if the slides can be shared. There was a question in the box from Kate about the rollout of the vaccine, particularly for people with learning disabilities and behavioural problems. What I would say is the vaccine rollout's been managed nationally. Very predetermined and prescribed arrangements are in place with 10 levels of rollout to make sure the most vulnerable population are accessed first and get that vaccine first. And you will have hopefully heard in the media yesterday, particularly a lot of talk in the media yesterday, that the rollout of the vaccine, the actual administration of the first vaccines, will occur tomorrow in the RVI for Newcastle hospitals. And this will be aimed at specifically people aged 80 and over, either in hospital or in their own home. But also at that same time, they'll be aiming to roll out into care homes for residents and staff. And when there are gaps in that programme, so if the appointments aren't taken up, they will use those gaps to vaccinate the at-risk NHS staff, so those working specifically on the front line in emergency departments, assessment suites and critical care areas. So that's the starting point. And the government have determined this is all available on there. We can share this with you. We'll find the link and share it out with people. It's all available from the government, whether cascading down in order of age, the priorities. But the one of the priorities, I think it's the second or third priority, is those vulnerable populations with multiple comorbidities, and those and learning disabilities people are on a register in the practices and should be picked up through that route. But again, we need to monitor that and keep this right. The national rollout or the regional rollout for our region is being managed through Newcastle hospitals. To supplement that, GP practices have got another rollout which they're dealing with for their own patients as an opportunity. So people have two options to go there, and there'll be many venues available. Not just your GP practice, but certainly in Newcastle, there are 4 venues identified, and in Gateshead, as we stand now, I think we've got 3, possibly 4 coming up, and these will be in leisure centres, conference centres, large buildings out in the community, which are easily accessible for car park and can allow access for people to go into those through one route come out through another route and enabling social distancing in the building while the vaccine's being administered. So there's really there's been a huge amount of work going on in the last couple of weeks to get to this point. We'll keep people informed of that. There's a major campaign about to hit the televisions and the newspapers everywhere else, outlining the whole plans that are about there for our region itself, and that's been led by a lady called Caroline Latter. I'm sure many have heard of. She used to work with us in the past around our comms and patient engagement work, which is now working across the region to make sure this is all put in place. It's been a very short period of time. We've had to, stand up and get this addressed and get premises identified and plans in place. But we are there and ready to start administering tomorrow. Alan, you've got your hand up.
Yeah, I'm just wondering, is there any information available about the rollout?
Yeah, we'll send that out as soon as we get the absolutely regional information. But we'll send out the national guidance with the notice. But we'll send them out with the slides of the meeting, the link to them, so you can see what their programme is. The challenge we've got, and I'll say it up front, is that national guidance has changed sometimes on a daily basis, and the criteria and the order of rollout has changed, and that's been based on new evidence coming to light and various things. So it's a kind of dynamic arrangement, dynamic process that does change from time to time, and that's been something we've had to grapple with in some ways during the whole of the COVID, where we've had changes in guidance and policy, and making sure that we keep up to date with that. And we do have a way of doing that, but we'll certainly share that with you, Alan, as soon as the notes and things are ready to come out for this meeting and the slides. David, you've got your hand up.
Hi, yeah, Chris. It's been a really useful meeting today, so thanks very much for everything you've all done. I've just got a couple of questions, things that I know are going around in my local area, and I don't know if you'll be able to answer them, but I just want to flag them up. I've been told the Outer West swimming pool is closed for good now. And I'm a bit worried about this because it's also attached to the local library. And I'm just a bit concerned, is COVID going to be used as an excuse to just close lots of services? I'm aware the council passed the swimming pool onto a group called Greenwich, the sort of like a kind of charity. And they're going around the country closing a lot of things like this. It's just saying that they're not feasible, they can't keep them open. And it's just really to flag it up. I don't know if the CCG can do anything. I know the council just keeps saying they've got no money. I have got another question, but I'll let you answer that.
Yeah, I'll answer that one first. Yeah, no, that's fine. That's fine, David. I remember the discussions we had around this building and the premises and how we wanted to make sure that we work together with that. And the CCG and the local authority do work closely together, particularly around the health agenda and public health agenda, which swimming fits into that. Yeah. So I'm not aware it's closing permanently, but I will find the answer out to the question on that front. But in terms of the libraries, my understanding is should be able to be accessed now, in the same way as other buildings can, using social distance and protection like that. But again, I will check the detail if that's changed. As I've said earlier on, policies and decisions are changing on a daily basis in respect of it. And there are different arrangements depending on whether you're in tier 1, 2 or 3. And of course, we're in tier 3. That shouldn't have resulted in libraries remaining closed, because they're being treated the same as non-urgent shop areas, for example, and you can open them now. But I will find an answer and get back, David. We'll share the answer with the group.
Right. And I do sympathise with what you're saying, that a lot of these decisions are being run nationally. And you as a CCG have little way of impacting on them. And this feeds into my next question, which is an article I've got in front of me about care home visits. And it's a group called Care North East that represent care homes, and they're very concerned that central government are making statements that people will be able to go in and visit the loved ones, no holds barred, if you like. And a lot of the care homes in the region are saying, you know, they can't just say that. And ultimately it's down to the registered manager to decide who gets in. Now, I've been lucky, I've been visiting my mum 15 minutes in a little hub they've built on a weekly basis. But it isn't very helpful, stories like this and what the government are saying, because I'm being asked by people in my street, oh, you'll be able to go in, you're being tested. You can go in anytime you want, you can sit with her and hug her and things like that. And I'm having to say that's not the case. And I would just be interested if the CCG has an opinion on what's going on here.
Yeah. Similarly, in terms of visiting in care homes, there is a regional group established which is chaired by Amanda Healy, who's the Director of Public Health for Durham. And I am on that group as a CCG rep for the north of England, and working with them. Our next meeting is at 2:30 this afternoon. Now the plans, and it is a national response again, is this lateral rollout, the lateral tests and arrangements that happen where a test is carried out, fairly straightforward tests carried out, and we can offer support to do that for people who need that kind of help, practical help to do that, and results available in 20 minutes. That's been tested at the minute in the south of the country to kind of see how it works, what the validity of the results are, and how well they are. Now, the views is, and I think the message given by the government is intended to be supportive to care homes and staff and visitors going into the care homes, and I think it's very difficult not to interpret that as being literal. It's not all in place yet, but we certainly are keen to progress having the at point of visiting testing for visitors to care homes to allow them to go in. We don't have it locally yet. We're working on that, but it's not all in place. There has been some concerns raised about the validity of this test, that it's not as accurate as the throat and nose swab. I don't know whether you've left the meeting, David. You seem to have meant to come back in again. But it is work we're actually looking at and looking at across the north of England with the guide. I don't have missed part of that because you seem to leave the meeting and come back in.
Yeah, I did miss most of it. My line dropped out. Sorry.
Oh, no, it's okay. I would just say it isn't that. I won't repeat it. But
No,
what I'll do is
no.
we'll make sure we send some response out with the slides and things so people can hear that.
Great.
I've
Thanks,
shared it with
Chris.
most of the group. Okay. Are there any other questions? There's a few comments in the chat box for people with updates. Dentists seeing adults this month, that's from Kate. And then libraries are doing select and collect, which is open from today for that. So that's a good move as well from Kate. And Anne sharing with us that understand about the vaccine organisers will contact people, and we not to contact them, that's right as well. And in light of the current escalation, so they've got to write a programme of delivery, and they will have names of people in those age ranges and who meet that criteria, who will be eligible for those tests, for those, the vaccine. Any other points to raise? Going to go on to my last slide, which is really just to say thank you to everybody again. I think personally, it's been a great meeting. I'm glad we've been able to continue to have these meetings and finally managed to get them in place. This is our third one, I think. The next one's due on the 11th of January, and the team will be working with the advisory group to come up with an agenda and a green agenda, which will circulate with you all hopefully the week before that meeting happens. Might be a bit of leeway this time because obviously we've got Christmas and New Year in the middle of that, which is a bit of downtime for people to have some time off where we can. And as usual, we've got the Survey Monkey link. The link, Dan shared that link in the chat box. If people can use that and complete that, would be great. But we'll also send it out as well to make sure you get a chance to complete it later if you haven't got time to do that now. And a written summary of this meeting will be sent out to included to those who were unable to attend today. And the recordings will be published on our website as ever. And happy holidays, as it were. Happy Christmas. Can't believe it's coming already. Come round in a flash. So I'll see everybody in January. Take care.
Merry Christmas.
Bye. Bye.